We're going to wait another minute, make sure everyone that is interested or logging in to get on before I get started. So give me about 30 seconds as I look awkward on the screen, and we'll get going soon. Okay. All right. It's 2:01 and let's get started. Let's rock and roll. Carrie, you ready? All right, great. It's great to have Carrie on today. She's going to help us with the sign language. And so thank Emily. I always like to start with thanking the foundation, Emily, Julie, Carrie, our interpreter, the people who make this possible. I'm really grateful that we have a foundation that's truly interested in mental health and wellness. And today we're going to have an awesome talk. It's a few weeks later than our May monthly awareness. I know mental health awareness was in May, but at that time, I think I had something I felt was more important was to advocate about people with paralysis. I was just recently hospitalized and had a lot of things I thought I wanted to share in May. So if you're interested in a little more advocacy issues, look at our May podcast. But so today we're going to talk about mental health and wellness in people with paralysis. It's a little slight change or a shift in some of my podcast themes because I traditionally focus on spinal cord injury, the foundation of the Christopher and Reeve initially, but now we are broadening the scope of people with paralysis. But in hindsight, when I think about it, a lot of the treatment, the process is still the same. So there's just little subtle differences based on the medical condition, but a lot of it continues to be the same. So we'll point that out as we have Dr. Hayward on, my friend Dr. Hayward out in California. She's going to be joining me today. Partway through this session, we're going to discuss some of these issues. So in broadening our scope of people with paralysis, there's about 1 in 50 Americans with paralysis. So that's around, with 300 million, a little bit over 300 million people in America. So it's about 5.4 million individuals. So that's a significant amount of people. And I guarantee you, many of them have issues that we're going to talk about throughout this next 12 months. Sexuality, relationships, depression, anxiety, adjusting to the physical limitations. So we're in the same boat, I guess, in some ways. So based on my literature review, 17% of Americans have anxiety, around 12% depression. But when it comes with physical paralysis, at least with spinal cord injury, it can be as high as 50% of us, half of us will experience depression or anxiety, or at least, so that is a huge number. And the problem is that a lot of rehabs don't have either time to address these issues, especially long-term recovery. I mean, think of it. How long do people stay in rehab anymore? So if you, let's see, those who are listening today, if you've ever been in rehab, how long does this, do you get an opportunity to even address mental health issues for a long term? Okay, so there's not a lot. So by the way, for those who have never been on my podcast, if you have any questions that you want us to address, either Dr. or myself or Dr. Hayward, put it on the chat. You can put it on there. And so at the end of the webcast, we are going to address some pre-registration questions and as well as podcast questions. So what populations are we going to talk about that's related to people with paralysis? Spina bifida, brachial plexus injuries, muscular dystrophy, a stroke. That's one area we didn't look at. Stroke, AOS. So there's a lot of neurological, developmental, genetic, vascular, infectious disease type of this that's going to relate to individuals with paralysis. So again, I state it's the shortness of rehab for those who acquire a disability like spinal cord injury. We're averaging 26 days in rehab. That's a huge change from when I was in rehab. Now, when I was in rehab, I was there 7 months. So it's 210 days. And even then, in those 7 months, I don't think that we didn't address mental health, or I didn't address mental health issues at the time. So for an injury like spinal cord injury, where you have a trauma and you go on and have an opportunity to discuss mental health issues, a lot of times we're in denial. I didn't think I was going to be paralyzed. I didn't think that I was going to have long-term. I thought I was going to walk. To be honest, I thought I was going to walk again. And part of that denial helped me motivate to work hard at the physical rehab part of it. It denied the mental part because I wasn't ready, but it allowed me to be motivated to want to work harder in physical therapy, occupational therapy, rec therapy, all those facets. Now, it's a little different if you're, born with a disability. If so the focus of some of those areas may be different because, you're young, you're not doing insight-oriented therapy. So it's more the parents initially that you want to focus the mental health. And as the child develops and grows older, then the shift becomes parent and the child. So there's a lot of different things to think about when you're talking about mental health. So let me give you some things that I've read, that I've learned over, as well as I learned over time. For example, self-esteem. Now, I'm going to ask the listeners today, yes or no. Just put a wire in, right? Yes or no. Have you ever had, or have you ever struggled with self-esteem in your lifetime? Now, so if you could put that on the Q&A, so I have one individual would only struggle with self-esteem. Okay, that's better. Absolutely. Miss Doran, yes. Okay, Robin, Cooper. So, yes, we all have. I mean, I would probably say that 90% of us have issues with self-esteem. So, someone with cerebral palsy, for example, how literature says, what's the best predictor of low self-esteem or high self-esteem? And in looking at the research, it's education, employment, and living arrangement. So you think of it, education. Well, I'm a huge supporter of education, employment, social interaction, and employment. Although if you work from home these days, it's a little less. And living arrangement, being able to live on your own. Those are huge factors for cerebral palsy or individual with spinal cord injury, or really any other disorders. Those that I've been exposed to throughout my life, if they live on their own, if they work, and if they are college educated, let me state it that way, college educated or higher education, they tended to be better functionally, mental health wise. Okay, so let me ask the listeners, if you have low self-esteem in your past, what did you do to make yourself feel better? What did you do? So feel free to put it in chat. Is there something you do that helps with your self-esteem? So let's see what our listeners contribute. I'm going to go down a few other different type of disorders. Spina bifida. Again, they talk about decreased mobility, anatomical deformities. These things make the experiences of life less satisfactory. Similar to spinal cord injury, bowel and bladder issues. Okay. Let's see. Others are, for example, body image. Okay. Body image. My God. How do we get around being different? Okay. How do we, yes or no? Have you ever been discriminated upon because you were physically different? Yes or no? There. Okay. Increase my self-esteem, talk to former colleagues and family. So Lisa. Okay. Susan says, yes, definitely been discriminated. Tom says, yes, I have as well, multiple times, multiple occasions, either if it's at a restaurant where they don't talk to me, or when I go out in public. It's part of our society right now. I don't think it's going to go away anytime soon. So our body image, our ability to feel satisfied of our body image is a big factor in how we adjust through our lifespan. So again, there's a lot of different physical disorders, but notably the pressure and stress of all this is still the same. So let's see. I am a T4 complete for 5 years. The most like I was a firefighter, firefighter, top of the game. Absolutely. Self-finished because of parabelly. Oh, yes, the parabelly. You should see the quad belly I have. It's difficult to hold that belly in when you don't have any musculature to hold that in. So when I was in rehab, I remember seeing a post 25-year injury individual come into rehab, and I was watching the individual, and I was just amazed that, first of all, he was 25-year injury post injury, but the fact that the person had a huge belly, and I was like, wow, that's what I'm going to look like when I'm post 25 injury. And the answer is yes. The belly comes, and the loss of hair. That's why I'm wearing a cap. So loss of hair. So if you wear a baseball cap, it's either you're real young and hip, or you don't have hair. So I think I don't have the hair part. All right. I look pregnant sometimes. Okay. Well, no one has ever asked if I was pregnant, but I probably definitely. Okay, cap on today. Good. Awesome. All right. So we have people wearing caps, and we have people wearing quad bellies like me today. Thank you for listening today. So coming on to this process, I will, again, address some of these questions. I see my friend Spencer is on today. My friend Sarah's on today. So thank you for coming on today. We are going to bring in Dr. Hayward here. Okay, because Dr. Hayward has a lot of insight in this whole process. I was just talking to her about how I was sick this year due to sepsis, common thing for us. I was developing a sore in the hospital, which is strangely, you think that's a place where you don't develop a sore, but that's where you go get sores these days. And I'm still recovering from that. And that was in March. So those of you who are been in a wheelchair most of your life, or many of you, do you have sores? Yes or no? I want to be inclusive today, because I want others to tell me that I'm not the only one that has a pain in the ass today. So Carrie, can you say ass in that on interpretation there? Okay, I don't know which one is that, but all right. So we had Dr. Hayward. Before Dr. Hayward says anything, let me brag a little bit about her. Okay, so she's a practicing clinical psychologist in Silicon Valley, California. Okay, uh, she does humanitarian work aimed at improving lives of people with disabilities around the world, and she spoke at the United Nations. So I mean, you can't get any better, higher than that. So she's so about eliminating ableism. So welcome, Dr. Hayward, today.
Thank you. I'm so pleased to be here.
Well, great. Yes, yes. So what are some of your thoughts about when it comes to I'm going to start with just they talk about just able-bodied people not having enough mental health treatment.
Mm-hmm.
What are your thoughts about people with disabilities? Is it easy for us to get qualified professionals that knows what they're doing and for treatment?
That's such a good question. And it's something that my good friend Dave Estrada and I have been looking at recently. He's in charge of the peer support network in the greater Boston area. And while they have a robust peer support network, there really aren't very many people that they can refer people with paralysis to for a little higher level psychological care. And what that's based on is that there simply aren't a lot of people who are trained in the disability experience. It's becoming a greater focus, having disability awareness of some sort and starting to include disability in the diversity conversation. But unfortunately, it can be very hard to find a provider, a therapist who has experience with disability.
Do you see what's the best avenue for someone to reach someone like you or me? Or what do you think? What are your thoughts on? Because what I've been promoting all these years of doing a webinar is that individuals with paralysis should either contact their local state association or the American Board of Professional Psychology for a rehab psychologist, because there is a group of us who are rehab psychologists who are trained. Is that the best way to come about? Because even local patients I see around here says, no, we don't know where to go. We don't know what to do.
Yeah, it is a really big problem, and stay tuned because we're hoping to crack the code. But for right now, I think that contacting one's sort of home center of physical care, of physical medicine for asking for a rehabilitation psychologist is definitely a great place to start. There's a couple of other robust therapist finder resources out there that aren't paralysis specific, but you can do search terms to see if they have any expertise that would be related. The two sources that I typically refer clients to are psychologytoday.com. That's one word, Psychology Today. And then look for their therapist finder tool. And then the second one is called Zen Care, and it's zencare.co. Co. I think if you go to .com, it goes to a different site.
Would you be able to put, or if our information specialist, someone could put that up for our listeners, the link, as well as Dr. Hayward? I know I just commented on your website today, so I know you have a great website. So can you make sure we post your website today if anybody wants to reach you?
Certainly. Here, let me put in the Zen Care. Oops, Zen Care. I just put in, and also psychologytoday.com, and then look for the therapist finder. And I'll put in mine in a second. What I would recommend if you go to a general site like Zen Care or Psychology Today Therapist Finder is that You see if they have any search terms that are disability related. Um, and but I think the most important part is to be a good question asker and advocate for yourself when you're first interviewing therapists. So you can choose, do a search, narrow it down to several people who look like potential candidates. And then when you're having your free 15, 20-minute consultation with them, ask them some key questions. I would recommend asking a question like, have you had experience with somebody who has acquired paralysis, or who was born with paralysis, whatever your situation may be? If they don't, you can ask them for a referral and they can tap into their network. Also, if you want to get more specific, you can ask them what their thoughts on disability as diversity, or see if they're aware of the social model of disability as compared to the medical model. And that is just a way to tap in to see if they have gone beyond some of the more stigmatized views of disability, because I think that's where we run into problems.
I noticed that you brought up the concept of, I just want to make sure my listeners heard you. If someone is following a social model versus a medical model, because my understanding of medical model is it's very dependency based model where you go to the doctor, they tell you what you should take, and then you really don't learn anything other than keep doing what they're telling you. Versus a social model, maybe a little more inclusive, a little more individualistic. Am I correct to say that, Dr. Hayward?
Absolutely. The medical model is the standard way that disability was once represented, as all of our disabilities are just medical problems that we as an individual are responsible for powering through and overcoming and trying to get fixed. Whereas the social model puts the responsibility for problems back on society. And so it would say the disability isn't really the problem, it's the lack of access, the environment, stigma, ableism. That's what really needs to be changed. And it is very supportive of civil rights for people with disability. And yeah, somebody just asked fixed. And what I meant by that is that would be the medical model, seeing disability as a problem that needs to be cured or fixed, rather than focusing on quality of life for people with disabilities.
Yeah,
How to improve
as you
that.
said, it's a quality of life. It's whenever I work with patients, I always try to tell them to focus about the here and now and not focus on being cured. Because I was told that paralysis was going to be cured 5 years, and that was in 1986. So we're aiming at 1991. It didn't happen. We're at 2023 and still not happening. So I guess what I'm saying is, focus on the here and now, addressing the issues like transportation, like ableism, like those things. So great. So if I'm summarizing correctly, look at some of these websites and maybe filtering out individuals who are more focused on a medical model, maybe, and focus on someone who's more inclusive social model, is what you're saying.
Right. Because you really want to find someone who can focus on your strengths and who sees you as any other human, but who gets around a little differently. You don't want somebody who's oblivious to all of the problems inherent in being in a minority population, like discrimination. That's real, especially in employment or education. So you don't want them to ignore that, but you also don't want somebody who focuses so much on the disability that they miss who you are as a person, and they miss the fact that you can have a vibrant life and do a tremendous number of things regardless of your physical status.
Now, I have to agree with you 100%, because my wife will say, it's not your physical disability that's a pain in the ass, it's you that's a pain in the ass. And I had to say, no, it's my disability. I'm blaming my disability, even though that's my cop out. And really, the reality is probably me and my personality at that moment. She's like, you're a pain in the butt right now. So, and with me being sick this year so much, she's like, man, you're like a gnat. I can't get rid of you for a while. So I've been trying to be more independent. I know you've gone through some things this year as well, and that's part of our life, isn't it? Sort of as we get older, we have physical things that we have to overcome.
Yeah, it's interesting. I always thought that once, like, so I have a traumatic onset disability from a car accident, and it was 29 years ago. And I always thought that the hardest thing I'd ever have to go through was adapting or adjusting to the trauma of my disability in the beginning. But it turns out that there's all sorts of secondary complications that come, and particularly come for me, started around 25 years post-injury. I was just telling John about the past 4 years for me. I've been having, I'm now on my 12th surgery. And these are for things like spasticity, a Mitrophanoff for bladder control. I broke a leg, and, just you name it. Oh, I tore my shoulder just from pushing, that sort of thing. And so learning a set of coping skills along the way, I think, really focusing on your armamentarium of coping skills is a great way to spend time, because life doesn't really get easier except, physically easier, but through having excellent coping skills psychologically, it can get easier.
Yes, I agree with you. The physical part, I think, if you just take away being in a wheelchair and just look at humanity as you get older, physically you start dealing with issues, and those become a factor. And if you haven't developed the coping skills to deal with it, it gets worse. And so I have a friend, Spencer, who's on listening, and he's a young 30-some-year-old kid, and I'm like, I keep telling him, learn, figure it out while you're young, because you're gonna feel these things as you get older. So I have on my list here, and I thought I'd get you some feedback from you, or your opinion. So the Spina Bifida Foundation looks at, here's some guide for mental health guidelines. Every disorder has their guidelines, which is awesome. I think you and I should need to put together like this little book of all the guidelines from all these different organizations. But what I like is that it says 0 to 11 months, we should, focus on the parents, because while the baby's too young, right? There's not a lot you can do with them, but promote mental health for parents and children, how the parents could influence the children. From 1 to 18, now it shifts. It says, let's, look at mental health for the child with spinal bifida across lifespan. How does the spinal bifida affect their mental health, and how to make them more resilient? And let's see. And again, the most important parts is how to adjust throughout lifespan. What are your thoughts on that? The time span and how they shifted over from more parent focused to the child focused later on.
I like it that they took a lifespan development model, because I do believe that our changes our needs change as we age. And in this case, change within where we're at on the disability continuum, meaning, well, in this case, newly born or newly injured. Folks will have very different needs than, say, somebody like myself, who is almost 30 years post-injury. So the needs do shift. I think I like that they use the word resilience. I did my my research for my doctorate at Harvard on resilience and post-traumatic growth, also on happiness with a spinal cord injury. And turns out there's a lot of things that we can do, changes we can make in our lives, or tools we can learn that actually increase resilience. And a lot of them have to do with other people, meaning our relationships, really investing in high quality relationships and making sure that we prevent ourselves from socially isolating, you know, making an effort to connect with others. For that reason, for myself, I've always maintained a core group of friends who have spinal cord injuries, as well as all of my other friends who are non-disabled. But it's been really important to me to have a group of friends who get it, who I can really talk to about what I'm experiencing from the perspective of paralysis.
So that actually leads us to our next area of thought, is the interventions, you know. So as a person, and I'm removing you, as you and I are sort of unique because we're both professionals in the field, but we're also both part of the network of being a person with that has a disability. So we have two perspectives. So you're just talking about, as a person within a wheelchair, surround yourself with a group of people who actually are understanding and compassionate and empathetic about your situation.
Absolutely. I've learned my most important post-rehab information from friends with spinal cord injuries, meaning like keeping up on the latest equipment, or I wanted to travel to Africa and how do I do that in a chair? And, questions like that. I've always found that the best resource has been other people in chairs or who use wheelchairs. And, but there's a really robust research body that's being looked at more and more that shows that if you had to choose one factor and one factor only that improves mental and physical health, it's the quality of our relationships. My advisor at Harvard was Dr. George Valiant, and he's in his 80s. He's amazingly wise, and he ran the world's longest longitudinal study on adult development for about 40 years. And so I asked him, I said, George, after all your years of being a psychoanalyst and a Harvard doctor and running this study, what is the key to happiness? And he said, other people, meaning our relationships with other people. And right now, the person who came after him just wrote a book. I'm looking at it. It's called The Good Life, and it's the results from the study. It's really excellent. I recommend picking it up.
The Good Life by
The Good Life by Robert Waldiger and Mark Schultz.
Okay. Maybe we can, information specialist or someone can put that up for our listeners. So here's a tough question for you then, Jen, and I will ask myself and I'll try to answer it as well, but I'm going to give you the first shot at it. How do we find good friends like that? Because, and listeners out there, yes or no, do you have a great friend that Shannon, Dr. Hayward is talking about? Someone that's compassionate, empathetic, it's understanding your disability. How do you find someone like that for our listeners? Where do you search for that? Walmart or a dating site, or where do you find someone like that?
Do you want me to take a stab at it?
Yeah, you're smarter than me, so you're a Harvard grad.
No,
so
I don't think so.
I want to know what's your perspective.
Absolutely. I have a number of thoughts on that. For me, I have a lot of friends who use wheelchairs, particularly spinal cord injuries, but some other disabilities as well. And I've gotten to the point where if I see somebody in a wheelchair and they look kind of like they're in my age range or something, I just introduce myself. And some people, don't love that. But the ones that do click and appreciate the fact that I made an effort to go out and introduce myself, have become fast friends. Other ways to do it, we all go through or had to go through physical therapy and rehabilitation. So I have a number of friends who I'm still friends with from when I was way back in the day when I was first injured. In fact, the woman who I refer to as my wheelchair role model, someone who I really admire how she lives, Ivana Brown is her name. I met her when I was only 3 months post-injury. And also other ways, there's a lot of Facebook groups and different organizations like like this one, or what is that? What is that other one? Oh, I'm forgetting the name of the other group that does peer mentoring.
I know the foundation, the Christopher Dana Reeve Foundation does peer. I think, like you mentioned, your friend, my colleague Estrada up there, your friend up in Boston, has a big peer-to-peer accounts. So what I'm hearing from you is, one, be, that's the word, you have to be, man, I am blanking out on words today. Outgoing, because you said you approach people,
Yeah.
So giving yourself opportunity to meet new people will obviously increase your chances of meeting someone nice.
Absolutely. And I did all of my undergraduate research and graduate school research on people with spinal cord injuries. So I had an added motivation to go out and collect people to be my subjects for my research. So I went to all sorts of ends to make, to meet people with spinal cord injuries. And there's an amazing number of resources like that. I think this one in particular, the Christopher Reeve .org peer mentoring is an excellent place to start.
Right.
I saw that there was a question about how do we find people who have the same kind of spinal cord injury. Can
I
I
like your
speak to that?
answer about Facebook. I mean, you can find probably a group about anything, any subset. That could be a good start, and if I was a patient, and again, I get patients that says, look, I just saw one you and I were talking about having privileges in different states. I just saw one in Nevada. I'm trying to make sure I got my sticker. And she's not very social. She's isolates a lot. And, my goal is to try to get her to be assertive, be social, because she knows the loneliness, the isolation has caused a lot of her depression.
Yeah, absolutely. It
And
really tends to.
so as a patient in your practice, that's where you would probably direct them.
Probably. I think Facebook is such a good resource in terms of finding people with niche interests, and there's also a care cure community of spinal cord injury for folks on the East Coast, I believe, where you can put in questions and get feedback. But there's a lot of us out there.
Right. There's a lot of us out there, but we seem to be isolated in different pockets unless you're in a big city. And are you in a big city? I know you're in California. I never really asked, really, where do you station?
I'm in Redwood City, which is about 45 minutes south of San Francisco. So I'm in the Bay Area, and there's a lot of folks with disabilities in this area. And I'm not that far from Southern California, which was where I did my outpatient rehabilitation. So that's probably where I have the largest number of friends in chairs, just because living in Southern California is so ideal for wheelchair use and sports, etc.
Yeah, that's one of the ways I personally adjusted through my disability. And there's a lot of people asking really good questions on the chat, and we're going to get to that in a little bit with Dr. Hayward and I. But I remember joining the rugby team, quad rugby team, and in the beginning of my disability, and that was a great way to be around people with similar views and thinner thoughts and really optimistic viewpoints of life, because they're already out there. They were out there for 5 or 10 years already. And so that was a big part of my adjustment as well. So I'm shifting gears on you. I'm going to try to ask a few of these questions. And so are you ready for some questions from our chat?
I'm ready.
Okay, so one anonymous attendee says, what could we be done to ease survivors' guilt? my stroke has put me in a position where I'm a huge burden in my family. I know that they want to help, but their quality of life has reduced. It's not so, stroke and individual, as a gerontologist myself who studied a lot of elderly patients or see a lot of elderly patients, it's a huge factor to, to have the stroke and be burdened at such a later part in life.
Mm.
What are your thoughts on the statement by this individual?
I think it's a really good question. And um, but I would question the fundamental assumption that of being a burden. I know that a lot of people who I've met through my research, also my travels, who are caregivers, they see that as part of what makes their life meaningful.
Mhm.
Being able to help other people, being able to help somebody else. And I'm not so sure that everybody who's in a caregiving role views caring for other people as burdening. Um, and I think that one thing that can be helpful, and I'm biased because I am a practicing therapist, but I do think that therapy can be helpful in that it gives you a way to take control over your own mental health, so that your mental health can be as uh, in shape as possible.
Mhm. Mhm.
Um, and so at least maybe your physical health requires a lot of care, but you can be maintaining your own mental health
Mhm.
and
And I like to add on a little bit of that as well, is that, you know any caregiver doing a lot of caregiving over time will experience some level of burnout. I mean, our literature keeps is showing that caregivers do burn out, and do get depressed and all those things,
right.
similar to the patient themselves. So to the person who posted that, I would say, you know, if you can't do it mentally on your own right now, get to therapy and find ways to help the caregiver by giving her time to take a break. Find other resources, so
Exactly.
that the person does get time off from you. I mean, I just mentioned at the beginning of this, being that I was disabled, my wife's been around a lot more than she usually was. And that was her indirect way of saying, you're a pain in my butt right now. I need, a little time. And so these are things I want to make sure I'm listening to my partners, and to make sure I hear what they're saying, because a lot of times we go so self-focused when we're sick. And unfortunately, so that's one of the things I would say, in addition to what Dr. Hayward said, is that you're right. Not everyone feels guilty about taking care of you, but we also want to make sure we give them time to take a break. Someone
Absolutely. Or
asked, I'm sorry,
yeah.
go ahead.
Right. Or I was just going to suggest that we look for resources for them, such as caregiver support groups. Um, and because I think that can be really helpful to people who are in that position as well, because it is hard and it is stressful. But to have their experience normalized and supported can go a long ways.
I think the foundation, Christopher Dana Reeve, has a whole section on caregivers as well. So please use that resources to help with the caregiving. Let's see, what is another? Lisa says she has a sore on her bottom too. Sepsis earlier this year. You know what? I should have a national sepsis group so we can all hang out. It just seems like that's way too common. Let's see. There was another question. I thought I saw someone that said, from Eliza on the second part. She mentioned that I feel like a burden as well. My husband's health has deteriorated so much since I become paralyzed. I know I'm a burden to my mom, who helps me so much and makes me feel so guilty. Yeah, Lisa, I'm feeling your pain. I think Dr. Hayward would say that she's feeling the pain. Although Dr. Hayward is a paraplegic, so I do, have a little animosity towards that, because she's very independent and she can run around the world without anybody like me. I can't do that, so I do get a little upset with her about that, though. No.
Sorry.
I'm just kidding you. You know that. All right,
I
so
know, I know.
so some resources are gone out, and let's see. Uh,
Dr. John, it looks like Eliza had a question about finding people with a similar type of spinal cord injury.
okay.
It says that she was paralyzed by a gunshot wound, and that is actually and feels quite alone because of it. However, that is actually the leading cause of paralysis for a number of groups of people of color.
Mhm.
And I know, for example, that in the Los Angeles area, there's Ranchos Los Amigos. You might want to look it up. They have a number of resources, and that is a spot where a lot of people, in fact, most of the people who I met when I was doing some outpatient rehab there, had been injured due to gunshot or due to violence.
Yeah, yeah.
So probably.
It used to
Mhm.
be 20 to 30 years old. There'd be more of a sports related car
Mhm.
accident. Now the
Yeah,
shifts has been more gunshot wounds and
yeah.
incompletes, right? And there's more incompletes out there than it used to be because medically they know how to treat someone right away
Right.
instead of throwing them on a stretcher and throwing some striker, pins on their head and say, wait, so they
Yeah.
do a lot of things to avoid the clotting. They, slow the body down by creating some temperature reduction, so
Mhm.
there's a lot of different ways out there. Yes, yeah, so Spencer just said it was a gunshot wound as well. So he's in agreement with you. Let me ask you a few pre-registration questions. We're a little bit towards our end of our webinar. It says the question from let's see, from Jackie says, how have you observed how levels of happiness are affected after unwanted physical changes in the body? What do your findings show in adapting to change, experiencing the fulfillment and joy of being stuck, suffering psychological disorders? What are some of the root causes? I sort of read a long one on that, but let me shorten it. How do you increase your happiness? You already mentioned that having people around you is one of the key. Having people around you that understand you is another key. Having peers that are similar. Have I narrowed it all down, or is there anything else that we should be looking at for happiness?
There's absolutely a lot of other things that we can do ourselves to increase our happiness level. Um, for example, mindset matters. With regards to aging or aging with a disability, there's a lot of research that shows that it's how we perceive aging that matters, that predicts whether we age well or not, or we age happily or well. Meaning, if we think of aging as a bad thing, then they had health complications and we don't age well. Whereas if we see it as like a challenge or an opportunity, um, people tend to live longer and have better physical health. So mindset matters. That's one. Therapy, again, putting a plug in for that. And I think Eliza, uh, who had the gunshot wound, that's what I would recommend. Doing some devoted trauma work, I think is important because unaddressed trauma will tank happiness. Also, exercise is nature's antidepressant. Even if you're exercising for 10 minutes a day,
Mhm.
doing something to get your heart rate going. And then finally, there's some smaller practices like a gratitude journal uh, or writing before you go to bed each night, 3 good things that happened every day, things like that, that have some evidence in the literature that shows that they can be effective. Um, yeah.
I use the behavioral activation all the time. Like a lot of times people will be scheduled with me, but I don't have time to see them for weeks. And I would say, look, if you do anything and you're waiting for me, start exercising, because the fact that you're just starting to move and you build up some natural endorphins, you're going to feel better. Now, literature does show that if you just schedule with a therapist, half the time they get better just by scheduling with you. So
Mhm.
I don't know if
Yep.
it's that or the fact that they're working out now. Maybe by the time by the time they see me, they're already buff and feeling good about physically. But so this may be another podcast down the road about medication. Uh, Trying to keep it short. What are your thoughts about mental health medications?
Great question. And my thoughts on that have really changed over the years. From before I was trained to now. Now I really look at mental health medications as just one more tool. Uh, they work for the majority of people, don't work for some people. And I've seen life-changing effects in some of my clients who have gone on meds either for their anxiety disorder or for depression or even for PTSD. Um, so I recommend, even if you're on the fence, at least doing a medication consultation with a psychiatrist, and with a psychiatrist preferable, or a nurse practitioner who specializes in psychiatric uh, matters, rather than your general doctor who has some knowledge but not the latest, like most fine-tuned knowledge. I think just doing that consultation and seeing what they think will allow you to make an informed decision about side effects and the probabilities that it will be effective in your treatment.
We're gonna have. I'm gonna have another whole podcast about mental health meds, just because, as you and I talked about before the webinar started, is that I'm in 2 classes from my postdoctoral master's on prescription privileges for psychologists, and as I gone through the classes, I went from one extreme to the other. Oh, I've never prescribed, to, oh man, this is critical. So I think I'm in the middle at this point. It is another tool, like you said, and in the process of treatment. Like any intervention, you got to try it. So hopefully, as I finish my 2 classes and have some knowledge about it, I can come back with a good podcast, a webinar about this. If should you be medicated? Because I don't know if you see, but I've seen people who are on meds for 25 years on the same dose sometimes, and I say, that's probably not helping you at all at this point. Your body probably needs it more than it is helping you. And there's others who really take it, and the side effects are so horrible that, so we're going to have to talk a little bit more about that. But one or two more questions there, Dr. Hayward. Let's see. My son is a C4 going through a horrible depression and can't get out of bed since February. Lisa's really worried. What do you suggest on something like that? I've had a case one time of someone who just didn't want to get out of bed. What are your thoughts on that?
Yeah, I've met with a lot of people who are in that position or in that shape. When I was doing some humanitarian work in Mongolia, I was carried up the stairs in a number of houses to see children who didn't want to get out of bed because of their depression. And that was a bit different because of the lack of resources. But here, where we have resources, if somebody is that clinically depressed, I think they need to be in therapy. They need to be in treatment, and telehealth has made it available to anybody at any time. Doesn't even have to get out of bed for the session. So I would engage a quality therapist who is trained in empirically supported methods, meaning those methods that have been shown to work in the lab and in the field. Also, have them consult with, or have your son consult with a psychiatrist, with a prescriber, to look at different meds. And there's a number of other treatments as well that are really effective for depression. For example, TMS and electroconvulsive therapy, even, or ECT, is really effective. And so there's new research on ketamine infusions. Right. That all 3 of those can be very helpful.
Yeah, and so from a medical standpoint, Dr. Hayward's talking about, you got TMS, which is it's like a brain stimulation without heavy duty stimulation. So it's, you put a little cap on or some type of electrode. With that, they will stimulate certain parts of your brain, but it doesn't hurt. I heard many people say it really doesn't hurt. Versus electroconvulsive therapy, which is zapping on these electrodes. It's usually done in a outpatient or a inpatient setting with a psychiatrist. And I've seen that done. It's very rough, but it's has great results for some reason. With some
Yeah.
side effects, but when it comes to depression, it really knocks that out. So for Lisa, I'm hearing get a therapist. I'm hearing get some meds possibly. And the third thing I would say is contact the local peer-to-peer, man. Get someone out there who,
Yeah.
oh, I'm sorry, I forgot to turn my phone off. Um, excuse me. So yeah, some peer-to-peer to get out there and talk to the person if you can, because if you go, Lisa, go after it from 3-prong, one of them may work. So so you got the ECT, you got the TMS, you got the medication. So one of those things may work. Let's see. We have one last question from pre-registration. How do you deal with able-bodied people who can't seem to stop focusing on your disability? And I'm going to start with this one first before I ask you this one, because I've always felt the belief is that, it's okay to be curious. You have to think of children who love to just stare at you and see what's going on. And I engage with the children like I would engage an adult. I would just explain what has happened. I'm about just being open about my disability, although there's some literature that says for younger people, there needs to be just, they don't want them to do that in the beginning. But for me, as a spinal cord injury, as a professional, I just let them out, educate the person so that they don't need to stare anymore. Okay. And, I have four kids that live next door to me that just moved in a few months ago. And one of the boys knocked on the door the other day when I came home, and he's like, can you come out and play? It's like, I love it when I get kids that want to come out and, play with it, because I physically don't do anything other than chase them around a little bit in my wheelchair. But the reality that they're interested in, me being part of their life already, that's interesting. So what are your thoughts on that?
I think that's great. The way that you look at it and interact with it, allowing people to be curious, and I think that's fine. And I think that if it reaches a point, however, and it sounds like it might have, where it's no longer working for you, then it's okay to have boundaries. It's okay to tell them honestly the way that their continued questioning, for example, makes you feel. And that's fine too. There's really no rules. It's about your personal comfort. Personally, I think I'm similar to Dr. John. I don't mind curiosity at all. If people make ableist comments or insults, which I've heard everything under the sun, then I do stand up for myself and treat it as a learning moment or a teaching moment, and and provide a little bit of psychoeducation. But for the most part, I've found that people are mainly just curious.
So yeah, they're just curious. They just want to know. But once you educate them, they sort of move on because they don't have the energy to keep staring at you anyway. So great. I'm gonna before I summarize today's podcast, is there anything you want to share, Dr. Hayward, that I didn't get to ask you? I'm going to give you an opportunity to summarize anything you want at this point.
Thank you. I think just some of the key takeaways are to reach out for help if any of these things are true for you: social isolation, depression, anxiety, post-traumatic stress disorder, because there's so much help available. And there's an added layer, however, to accessing help when you have paralysis, which is you might need to ask a few more questions up front to see the practitioner's level of experience with the condition, and to get involved in any capacity that you can so that you make quality relationships, or at least are just around other people. And that can go a really long way for mental health.
Great. Thank you, Dr. Hayward. I want to thank you so much for coming on today. You and I, every time we are together on our webinars, we seem to do a pretty good job at interacting and educating. So I thank you for coming on. I hope you continue to want to be on in the future as we go through our different monthly subjects. So thank you, everyone. We, to summarize our podcast today, and it's mental health it's huge. It's getting bigger in the sense that people are more aware of it. It's more accessible. It's as you look at what's out there in the world, it's people are talking about mental health. If it's about gun issues, if it's about children and adolescents, it's a big factor. And I'm so glad that it has come this far in my lifetime. And I think there's a lot more to go as more educated we are now. The thing is, I noticed that there's a lot of meds out there now. Again, maybe because I'm in school about all this, there's a lot of medications out there that feels like they can treat everything. And so that's a whole nother topic again. So please, if you have any questions, feel free to email me at the university. I don't have the email set up. If you have questions for Dr. Hayward, I think she has a website. You can probably contact her through there, correct?
Yes.
Yeah, so look for her website, and if you need to ask her questions, some of you have asked a lot of questions in the chat that I didn't even get to ask, so feel free to email her or myself, and if we will do the best for us to try to answer some of your questions. I'm not sure what the next month's topic. We'll come up with something and I'll get it out to you, everyone in the flyer. Feel free to suggest some topics if you're interested. And thank you very much for attending. We will see you next week. And I have to thanks Keely, my great assistant here. I can't do many of these things without her next to me. So thanks, Keels, for helping me. All right, everyone. Take care. Have fun. Enjoy the summer. I apologize. I moved around a lot in this session because my butt was, trying to shift my weight a little bit. So I like the way you did that, Carrie, the shifting weight thing. That's so thank you. Have a great day. Enjoy. See you next month. Bye-bye.